So here in Section C, we will continue the application issues, and then we will end up with some of the things that we are doing here at Johns Hopkins, as well as some suggestions for learning more in the field. The first slide in this series is a very exciting slide to me and really continues on the theme of merging data together. Those of you in Maryland, or even those of you not in Maryland, again, it's been considered a model for the nation. Again, as of January 2014, the plan is for it to continue the next 5 years and be a model for future healthcare, often called the all-payer population health-based global budgeting system. That's a mouthful. There's something called the Health Services Cost Review Commission, HSCRC, or Maryland HSCRC. If you go to its webpage, you'll find all of this and more. Actually, you won't find this slide, but you'll find a lot about the all-payer waiver. So here in Maryland, Medicare, Medicaid, the two government programs, Blue Cross here in Maryland called Care First, as well as all the private insurance organizations, and Obamacare, often called qualified health plans, they're private health insurance plans, and those that remain uninsured, they all are part of this deal. So it's everybody. It's quite profound. Every hospital has bought in, or almost every hospital has bought in. They will be paid, as I alluded to earlier in the presentation, not just for what they do in the hospitals, but also how healthy their communities are. I and colleagues at our Johns Hopkins Center for Population Health IT, CPHIT, and others across the state, I call it a moon launch, are trying to help the state, HSCRC and others, really pull together data sources from a variety of locations. And this is a theoretical presentation done by my colleague Hadi Karasi, who is the assistant director of our CPHIT'S Center and assistant professor here at the Bloomberg School. But this is an attempt to provide a new population-based model for how one takes information from consumers, from electronic medical records, EHRs, from our health information exchange, in Maryland it's called CRISP, from the Department of Health and Mental Hygiene, DHMH, to develop a full population data source. And we might pull it off, not because we're so smart, but because the hospitals have to do it. I've learned that, you can have good ideas, and you can have a good health department, and academics can help out, but unless the financial alignment is there, which it certainly is in this state, these things won't happen. So I encourage you all to check back in the future, and if you're interested in this, I'd recommend you go to the Maryland Health Services Cost Review Commission site. Let's shift gears a little bit away from structured delivery systems and talk a little bit about consumers. As I showed you in the previous circle graphic in the previous section, clearly providers are important, but so are consumers. And things are very dynamic on the consumer side. I bet you all of you have health apps, applications on your mobile phones. You probably have various bookmark sites on your laptop for health, and I think this will, and any of you that are involved as clinicians or public health professionals, obviously interact with your patients as consumers. An interesting analysis done by a spin-off of Google, so you have to take the source into consideration, but they do good work. They did a survey of consumers and asked them, what is your top source of information of health concerns if you have a problem? And you'll see that the number one, I think general practitioners, family doctors, and primary care doctors are happy to see that they're number two. But the number one by far source of information for patients or consumers is the internet. Think about it. If you or a family member have symptoms, particularly if you're not a clinician, or even if you are, you're not sure about it, where do you go? You go and you check internet sources. And you'll see that other medical sources are on there, but nowhere near the top. I don't think this slide actually comes from Google, but it's a cute one. The idea of sometimes called click chondriasis, or increasingly, with the camera on your laptop or on your phone, as this poor patient is doing, the doctor can actually look down your throat. So I think increasingly the consumer role will be very dynamic. I and a colleague, you can find it on PubMed, and a colleague, David Blumenthal, he was actually the head of the federal government's IT ONC for a while, wrote an article in 2013 in Health Affairs, which is a well-known policy journal, you can find it on PubMed, about the implications of this trend in consumer health and the implications of all of the medical trends on how doctors and patients interact with one another. And we actually came up with some estimates that fully a fifth or some high number like that of interactions between doctors and patients will not be necessarily in the same time and place. Sometimes the doctor or the nurse will be in a different location, sometime at a different time. And also we discussed the concept of telemedicine and e-referrals, the next slide. 15% or more of care will be in real time but will be remote. Large health systems, as you know, in this country, although we have plenty of doctors, some actually think we have a shortage. I think they're actually in the wrong place for many reasons. But rather than trying to move doctors or other clinicians where they don't want to be, that we can provide care through telemedicine. And these three slides, I believe one's from Pennsylvania, one from California, and one from the VA system, show primary care doctors or nurse practitioners that are getting support from providers in a different location through e-referrals and telemedicine. So the implications for those of us in public health concerned with special communities are profound. I alluded to the whole area of mobile health. In fact, here at Johns Hopkins, we have something called the Global mHealth Initiative, GMI, handled by Dr. Alan Labrique, Labrique. If you are new to the Hopkins community or interested in mHealth, I'd encourage you to check out their webpage. What is happening is everybody, 90% of the people have cell phones, and increasingly, of course, globally they're called mobile phones, not cell phones, hence the M in mHealth. And increasingly they're smartphones, that is with internet access. There's more computer power in your pocket than your doctor 10 years ago had in her entire office. And so there are many companies. Here's one actually based in Baltimore, one of the biggest successful startups focusing on phone apps for diabetes called WellDoc. Thought I'd give them a little plug. And then another one doing EKG devices. The implications are profound. And as some of you might know, particularly if you're interested in issues in developing countries, technology and mHealth is far more accessible than it might be a full EMR system. So today, I would say here at the Bloomberg School of Public Health, most mHealth applications are probably focusing on developing country issues or other low resource settings. If you haven't yet, the next slide gives a nod to Microsoft's personal health record called HealthVault. Of course, the whole issue of security is very big in healthcare. By the way, we have many security experts here at the Whiting School of Engineering, and they have a team of which I'm supporting with other computer scientists across the country, trying to develop hack-proof systems. And of course, it's really twofold. Not only is it the technology of protection, but also the ethical and legal support infrastructure that is necessary. And sure enough, our Ethics Institute and legal colleagues here are also quite interested in the whole issue. But to date, most of the data breaches, I don't think I've discussed that, have really been more about going after credit card information that may be in the medical care system, not medical information, but fully acknowledging that no talk would be complete without discussing that. So all of you should go to Microsoft HealthVault site. Some of you are traveling a lot around the country, around the world, and developing your own personal health record. And increasingly, the doctor's EMR and the patient's personal health record, Microsoft HealthVault being the biggest right now. By the way, it's not that big, although 85% of doctors have an electronic health record, electronic medical record, probably only 5%, 3% of patients. So I think this will be a big growth area. I think on the next slide, I've already alluded to mobile health apps. And for low-income nations, I think it's really great potential advances. So, in a poor sub-Saharan African village, 2 or 3 mobile phones may be the entire digital infrastructure, but the possibilities are really quite profound. Although putting a plug in for the Global mHealth Initiative, and there are national mHealth alliances and global alliances, remember, a phone app does not a health system make, or a phone app does not a public health intervention make. It really has to be part of a broader infrastructure. I've alluded to it before. I wanted to share this slide of the Accountable Care Organization, ACO. ACOs are part of Obamacare, that is the ACA, really focusing on the federal Medicare program. It's a way of making virtual HMOs, virtual integrated delivery systems. But I like this slide because it shows you, if you look at the concentric circles here, and the types of things an ACO do. You see the light blue circle? What it has here is population, health IT, and data management. So the future of healthcare, this is how I started the talk, sort of the future infrastructure of healthcare includes both health IT and population health, pulling together the disparate hospitals, doctors, and the different agencies, including public health, that are shown here. More specifically, in the population health informatics domain, particularly applied by accountable care organizations, health maintenance organizations, HMOs, other types of sometimes called disease management organizations. Now they're increasingly called care coordination organizations. These are some of the tasks that for those patients heavily with chronic illness here at the Johns Hopkins Healthcare Organization, JHHC, Johns Hopkins Healthcare, is sort of our HMO arm for students, employees, Medicaid recipients. So here at Johns Hopkins Healthcare and other organizations, we have new applications in chronic care that include identifying sort of the risk pyramid. Who is at greatest risk? Who should the nurse practitioners, nurse case managers reach out to? Again, our Johns Hopkins ACG system, which you can find online, is widely used by many organizations, including Johns Hopkins, for that purpose. It scans all of the diagnoses, all of the pharmacy information, and since the nurse can't reach out to all 300,000 members of the health plan, she or he in any given week may only reach 50 people who are in greatest need of her help. In addition, various types of consumer education programs through internet and apps and others are being used. As we've alluded to, various types of clinical decision support and guidelines are being pushed out. One of the challenges with guidelines is it's all well and good to embed it into one computer, but if for a population you have many members of the community getting care from different computers, how do we make them talk to one another? I think supporting the patient through a web portal, increasingly the Johns Hopkins MyChart is using the outreach to patients as really part of the population-based process. We have here at Johns Hopkins an accountable care organization that focuses on people that use Johns Hopkins. We have something called the JCHIP project, which is actually an outreach going for people who live in the community. And as I mentioned to you, we also have this all-payer waiver. So it's during the interaction I'll have with students that are in Dr. Schoenrich's class, we will be discussing that further. As we wrap up the presentation part of this section, I thought I would summarize some of the challenges and issues that the field will face. And frankly, many of you as future leaders of the field will need to resolve and grapple with. And again, it's a very exciting time, both today and frankly, I predict the next 10 or 20 years. This is going to be a long-haul process, and I'm very excited to give this presentation for that reason. So even though I and others are excited about the opportunities and am firm that they are opportunities, resources are not unlimited. It's true that President Obama and the HITECH Act, so-called meaningful use, has put a lot of money into the system, and it's true many health systems have added to that investment, but that can't continue forever. So clearly the ROI, return on investment, of all of these digital systems, just like we're critical in public health on medical technology or any type of technology having an impact, benefits, we need to likewise put the searchlight, the magnifying glass on the investment of health IT. Secondly, I've alluded to this in many places, and each of you have a different perspective as well. There's public health, there's society, there's providers, there's individuals, there's patients, there's ethical issues. How do we tie them all together? And the third bullet on confidentiality is a nod to that. Now, I think that whose data are it? This concept of if it's a government health program, yes, patient confidentiality is essential. You or I, as patients or providers, want to do that. But if the data are procured by society and we pay for it through government programs, or the data are necessary to benefit all of us, such as in the case of surveillance, how do we handle it? So that is, great implications over the future. But the so-called HIPAA, HIPAA, we've got it covered 80% of the way, 90% of the way for insurance data. We need to bring it the rest of the way for EMR data. Any of you that have ever worked with a new computer or a new phone app understand, certainly any of you that are experienced in the field of health informatics or health IT, appreciate it's not just about the computer. It's really about the human-machine interface. And it should not be underestimated how complicated it is. I mean, some have said if we can only make the clinical care or the population support as easy as it is on an iPhone for the public health professional, we're a long way off. Any of you clinicians that have ever used an EMR, or any public health professionals that have ever used vital record systems, know it's not exactly as easy as your Android or iPhone. I think as like everything we do with public health, the concern between the haves and the have-nots, the special populations, the so-called digital divide. It's surprisingly an awful lot of people in poverty also have access to the internet on the iPhone. But clearly, when we talk about community health or population health and IT, it can't just be for those that have a certain equipment. It has to be for everybody. In this country, we are a multifaceted society. Our healthcare system is really made up of many components: government and public health agencies, payers and managed care organizations that are really the source of most of the money, obviously, consumers and individuals. Providers are yet again separate, and the vendors, in this case, meant to be the health IT industry or EMR industry. So these are not trivial issues, figuring out whose roles people will play. And from the perspective of this talk, we're talking primarily about population health. So now that I've completed an overview of the field of population health informatics, population health IT, I wanted to say a few words about our new center, the Center for Population Health IT, or CPHIT, here at Johns Hopkins. And I'm very excited about our center and how we will put in place, both here at Hopkins and in Maryland and in the U.S. and for the globe, some of the things that we've just discussed in this presentation. So now that I've completed an overview of the field of population health informatics, population health IT, I wanted to say a few words about our new center, the Center for Population Health IT, or CPHIT, here at Johns Hopkins. And I'm very excited about our center and how we will put in place, both here at Hopkins and in Maryland and in the U.S. and for the globe, some of the things that we've just discussed in this presentation. On this slide is a summary of sort of our mission and focus. CPHIT has a very simple goal, that is to improve health and well-being of populations by advancing the state of the art in this field. But our real focus is really not clinical informatics. We really are targeting both public and private organizations and agencies. And we will be focusing on pretty much everything that we've talked about in this presentation: electronic health records, e-health, but with an emphasis on what is the right side of the concentric circle graph I showed you. I mean, should I say the largest population sphere on the right, and then the largest sphere on the left, which was the integrated delivery system. Although this center, CPHIT, is based at the Bloomberg School of Public Health within the Department of Health Policy and Management, where I hold my prime appointment, it really is a cross-organizational collaboration here at Hopkins. We're working with the Johns Hopkins Health System, which does include a population health component, Johns Hopkins Healthcare. We're working with colleagues across the institution, including Computer Science Department and Applied Physics Laboratory and many other. The Division of Health Sciences Informatics is a very important unit within the medical school. We certainly are collaborating. We see collaborators, any of you that are listening to this, public health agencies and in integrated delivery systems and in health plans. And like everything else we do at Hopkins, although there's some internal funding, we seek outside funding from government agencies or foundations or corporations. We also, recognizing that in the field of IT, we certainly are an academic unit with publication and helping the public domain. But like everything else in the IT industry, it has to be shared with the world through technology and through corporate ventures. And again, our Johns Hopkins ACGs, which I talked about earlier, a predictive modeling tool, case mix system, is one of the biggest technology transfer successes here at Johns Hopkins. So we're collaborating with business partners and with units here at Johns Hopkins that specialize in that. Our CPHIT Center, our goal is to become leaders in this domain. And elsewhere on our webpage, you will find information on recent national conferences that we've had. Again, as I speak to you in 2014, we've recently posted presentations from this national agenda setting conference, as well as in the near future, white papers with our deliberations. We clearly are a research and development unit that collaborating with organizations across the country, as well as faculty colleagues. We're working closely with our own health system, bringing in EHR data, and I'm very pleased that as I speak to you, there are 4 or 5 organizations we're working with around the country that have shared data with us in exchange for our use to advance knowledge, as well as tools that they can use in the population health domain. And of course, we at CPHIT are very connected to the educational mission. I direct the population health informatics program here at Johns Hopkins. Some of our agenda items, you can read more of this on our webpage. I'll go through really quickly. For our research and development, you can also download information on the CPHIT webpage that describes it more fully, is measuring health status and quality measures from electronic health records. You'll find publications on this. Easier said than done. Don't forget the EMR was designed to treat the single patient, and developing measures that are uniform and usable that meets reliability and validity standards is not so easy. About 50% of the information in electronic health records is not structured. It's so-called unstructured data that the doctor or nurse just puts in like they were typing, often called free text. Working with collaborators, mainly in the computer science department here at Johns Hopkins, we're doing natural language processing and pattern recognition, sometimes called text mining for NLP. Clearly, right now, there's a lot of silos. As in my presentation, we talked about all those different sources of data, the consumer data, the public health data, the EMR data. We're pulling them together. We're very excited as we speak to work with the Veterans Affairs organization to pull data for them for population health. We have projects ongoing with various other federal agencies and state agencies trying to do the same thing. Given that ACGs, as I've alluded to, are widely used across the country, heavily with administrative and claims data, we're now developing new tools using EMR data, and that's an exciting, sometimes we call it the EACG project, and that's tied in to CPHIT, and we're all types of new data sources that we did not previously had. Clearly, the whole issue of how the private and public health sectors can work together, there's some exciting discussions we're now, and I'm sure will come to fruition one way or the other over the coming years, of how we can integrate medical, public health, and social data, human resource data, that is non-medical data, to improve the population health. And yes, I fully acknowledge, although this presentation has been heavily talking about public health agencies and medical care, I think as most of you experts in public health and population health know, without housing, without food, without exercise, with smoking, you'll never have good health. I think the legal and policy infrastructure in the Department of Health Policy and Management are really critical. I think we at Johns Hopkins, other colleagues, as well as some of us in health policy and management, are national, international leaders in quality and safety improvement. The implications, and many consider that to be a public health, population health activity. We look forward to working with colleagues to ensure that all of these systems, as they're rolled out, will improve quality and safety. We've already talked about the integration, but this is really more at a macro level, bringing it together. And then lastly, we and other colleagues need to develop tools and frameworks, particularly for the field of population health IT or informatics. I think it's exciting that's happening more in medical care. So this is quite an agenda. If any of you either inside the Hopkins community or outside in the academic or policy community hear this and would like to participate in some of our activities, we would be very pleased to communicate with you about how we might work together, and I encourage you to reach out to us. If you'd like to learn more, both about CPHIT and about the general field of population health IT, on the last two closing slides, you can see the CPHIT webpage. The first bullet, you'll see our new videos that we've recently put up in 2014 from leaders in the field from a recent conference that we've had. And I encourage you, as I mentioned before, to download information on that. For those of you that are not part of the Hopkins community, and if you're interested in furthering your education, here's a certificate off-site, completely based on the web, and the credit can go toward a degree, either here or elsewhere. If I haven't yet shared it with you, there are at least 3 or 4 different centers here at Johns Hopkins. The web pages are good sources of further information. The Division of Health Sciences Informatics, called DHSI, at Johns Hopkins. You'll see the web page noted there. And the Center for Population Health IT, you'll find the web page on the next slide, and the Global mHealth Initiative. I encourage you to check out those locations, and 2 federal web pages. So again, thank you for listening to this presentation on the CPHIT site, and I hope that you can be part of the very exciting field and solution wherever you may be in the health or public health system. And again, please feel free to reach out to us at CPHIT.